So we've talked about HER2 positive disease and not continuing treatment past the first line. What about our HER2 negative patients who are going past first line therapy, now have progressive disease? Let's talk about what treatment options are available and how do we choose? Ramucirumab.
Right.
Manish, tell us about ramucirumab and how you use it.
Right. So ramucirumab is an important drug based on two large phase 3 studies that demonstrated benefit in the second-line setting versus best supportive care, as well as in combination with Taxol versus Taxol alone. Ramucirumab is a VEGF-R2 inhibitor. It's different than bevacizumab, which is a VEGF-A inhibitor. As you know, we examined bevacizumab in the first-line setting in gastric cancer, and that was a negative study. Recently, ramucirumab was also examined in the first-line setting and also a negative study. So really, ramucirumab is actually the targeted drug that we would choose, whether you're HER2 positive or HER2 negative in the second-line setting. Although it is, as David likes to say, NCCN approved in the second-line setting, we would mostly use it in combination with Taxol or paclitaxel. The other second-line drugs that are available, single-agent taxane or irinotecan, I think we really should not use these. I think the go-to regimen in the second line should be Taxol and ramucirumab.
And so what about for a HER2 positive patient? We're not supposed to continue on treatment. Do you use ramucirumab plus a taxane, David?
Yeah, absolutely. There's not any differential effect for HER2 positive, HER2 negative patients. And I think the development of paclitaxel ramucirumab really revolutionized and established a global standard second-line treatment, not only in Asia but also in the West. I mean, the REGARD trial was proof of principle, really comparing ramucirumab versus best supportive care in second-line treatment. Although there weren't many responses, there were progression-free and overall survival benefits. So the drug did have some single-agent activity. But more clinically relevant is combining the drug with paclitaxel. You had augmentation of response rate, up to 30% of patients responding to second-line therapy. 2-month improvement in survival, where a median survival is extended out to 9 months, which was unprecedented for second-line treatment, and improvements in progression-free survival, so without any detriment in quality of life. So paclitaxel ramucirumab is really the go-to standard second-line treatment, and I think a complicating issue is now patients are getting FOLFOX, and now with upfront, so the neuropathy baseline is an issue. Now with paclitaxel ramucirumab, patients are on taxanes longer. Sometimes we're treating patients with paclitaxel for a year when we would treat them for 6 months. So we have a clear defined second-line standard of care, and this is probably the most appropriate platform for combination therapy in the second line. One of my criticisms about a number of the recent second-line trials is they used paclitaxel alone as a control arm, which arguably is inferior. And I think we can talk about this a little bit later, but ramucirumab, because of its low toxicity profile, is a good partner for other drug development.
So tell me, would you ever use ramucirumab as a single agent?
Yeah, I think it's a stabilizing drug. I mean, you do get modest progression-free and overall survival benefits, but you don't really get responses. So sometimes I do consider it as a maintenance therapy in patients. If they're still responding to paclitaxel ramucirumab and have neuropathy, we might continue ramucirumab alone as a maintenance treatment. Arguably, however, if the patient isn't well enough for combination chemotherapy second line, are they really going to benefit from ramucirumab monotherapy? So it's a rare patient that I'll treat with ramucirumab monotherapy. I think paclitaxel ramucirumab would be the de facto standard.
I'm going to hit you with a couple clinical pearls questions. So one is, and this came up when we started using bevacizumab for patients with colorectal cancer. What if you have a sort of known lesion with history of bleed or maybe slow bleed that you're suspecting? Would you use ramucirumab in that setting?
Yeah, we really did not see an increased risk in bleeding or perforation with ramucirumab. They're really rare scenarios. Manish mentioned earlier the use of palliative radiation for a bleeding tumor. I think if someone's actively bleeding, getting transfusions on a regular basis, I think I probably would get radiation in first. The other, if the patient had a history of a previous perforation of a tumor that they survived, those are, to me, would be contraindications or hypertension that can't be controlled. But the drug is quite well tolerated.
Okay, one more clinical pearls, and I'm putting you on the spot. So you mentioned neuropathy, such an issue with our GI cancer patients. And I see patients being treated with a full gamut of different agents, from the super B vitamin complex to ginkgo biloba to gabapentin, bumping the doses higher and higher and higher. What's your take on pharmacological treatment of the neuropathy?
Yeah, I think the only patients that I treat with neuropathy are when they have painful neuropathy. And then drugs like gabapentin, I think, play a role. Unfortunately, there really isn't anything that effectively treats the neuropathy, but if they have painful neuropathy, then we use neuropathic pain medications. I mean, my colleagues can comment.
I agree.
Yeah.
Stop and go fashion is the best way to prevent the persistent neuropathies.
Yes, yes. You've used the...
Yeah, that's an important point, stop and go. And continuing Ramucirumab while you're taking a break from taxanes may be very helpful. The other drug that I use for neuropathy is Cymbalta.
Yeah.
That sometimes seems to help as well. And then alpha-lipoic acid sometimes has helped as well. The other thing that people have sort of talked about, which I actually haven't seen that effective, is the neuropathy, is the use of magnesium and calcium infusions during the infusion. And I don't do that for taxanes.
The randomized trial data indicated no benefit for calcium magnesium. It's really kind of become an abandoned treatment.
So Kohei, when we originally looked at data from Avogast, the bevacizumab in the first-line setting with chemotherapy, they said, oh, well, it's just because patients in the East don't benefit from angiogenic inhibitors, patients in the West do. Tell us a little bit on your take on that, and does that affect your use of ramucirumab treatment? What did the trials tell us?
So actually we use paclitaxel and ramucirumab as a standard treatment. It is recommended in Japanese guideline. We enrolled 140 patients for Rainbow trial, and the subgroup analysis suggested the doubling of response rate and the PFS even in Japanese patient population. So actually, survival in control arm is remarkably longer than that of the overall patient cohort. So hazard ratio in Japanese subgroup is 0.87, but still favor their combination arm. So that's why we recommend this combination as a standard treatment in Japan. So actually, in clinical practice, maybe I use more than 80% of patients in second line with this combination. But still, I stop to or carefully select a patient. If patient had a massive ascites as well as a dilatation of small intestine, it may have some risk for GI perforation. So I usually start paclitaxel first, followed by combination carefully. But most patients can receive the combinations. We also can use nab-paclitaxel. This is one of the taxanes agent with reduced frequency of infusion-related reaction. So we can use without any pre-medication, only 30-minute infusion. So the nab-paclitaxel is also approved in Japan. So sometimes we use nab-paclitaxel and ramucirumab. And our phase 2 trial showed more than 50% response rate in second line. So this ramucirumab-based second line is a standard treatment, even in Japan.
And tell us a little bit about TAS-102. We have the positive TAG study. Tell us a little bit about that, and where do you typically use this?
Yeah, TAS-102 is already approved drug before colorectal cancer. And previously, we conducted the phase 2 investigator-initiated trial and suggested some disease stabilization in patients who refractory to 2 or more previous lines of chemotherapy. So that's why we conducted this TAGS as a global trial, which compared TAS-102 and the placebo in patients who refractory to 2 or more previous lines of chemotherapy. So this is a criteria for trial, but actually in Japan, most patients previously received 3 or more lines of chemotherapy. That means first fluoropyrimidine platinum, paclitaxel, ramucirumab, then irinotecan. So we are still waiting for the approval in Japan. Maybe in next next few months, but maybe we can use TAS-102 as a third line or later line.
Yeah.
So after paclitaxel, at least paclitaxel and ramucirumab.